Hello, Andrew Colsky with Therapy BTS, Therapy Behind the Scenes. And today we have a guest, Dr. Dan Villiers. Dan is from the Anxiety Institute, and he's going to talk to us today about what they do and a little bit about himself. So, Dan, could you introduce yourself to the audience for me?
Yeah, I'd be happy to, and thank you so much for having me. Yeah, my name is Dr. Dan Villiers. They call me Dan or Dr. Dan. I am originally from England. I moved to America when I was 13. I mention that because it's sort of a part of my personal journey and experience from what was a place of very high anxiety. So I have this sort of personal story. But I moved to California and went to a very nice school near Santa Barbara. Couldn't have been more different than England. And right around my junior year, I started to experience. I didn't even know it at the time, but what was acute anxiety attacks, panic attacks, and they were the kind of symptoms that are really visible. So sweating, flushed skin. I mean, you couldn't hide from it. This was also a time, whenever this was, early 90s, where there wasn't the awareness of what anxiety was. I mean, there's still stigma now, but not like then. And it got increasingly worse, and there was a therapist, and I did meet with that therapist, and we talked about it and processed things, but it didn't seem to fix it. And it just gradually got worse, where my avoidance increased too, to the point where actually I dropped out of high school the end of my junior year, moved back to the UK, and obviously didn't feel good about that, not fully knowing what it was at that time, actually hoping it was something medical or organic in some ways, as maybe a lot of people do. And finally found a therapist that said, okay, based on everything I've heard, I really think it's this, which was panic disorder and agoraphobia, social phobia as well. And that provided a little relief, but it still sounded like maybe it's my dad in my head, or the British culture I grew up in, of, just relax, or, just control it, just push through it.
Mhm.
I didn't have this language back then, nor the confidence, but if I could, I would. I'm not stupid. you know,
Right,
Something I
right.
tell my clients to think about. No one wants to be anxious, no one wants to be depressed, right? And cut a long story short, I mean, I saw a lot of therapists and that didn't really work out, all well-meaning, well-intentioned folks, but it wasn't until I discovered someone that could provide really good cognitive behavioral therapy and intensive therapy. So we were doing 3 days a week. They were half days, Monday, Wednesday, Friday, not limited to an office. We were out on the streets of London chasing down anxiety. I mean, it was
Wow.
incredible. It was terrifying as well early on, and a hard stop. But I mean, and I remember a lot of the lines that I'll say. I need to give credit to him and other people I've learned along the way, and students that I've worked with, or clients.
Mhm.
But he was in the business of inducing anxiety, as we are, as the Anxiety Institute is, and we do it in a gradual, controlled way. Controlling the pace, the content of it is so important, because it's all about desensitization, getting comfortable and habituated, and there's lots of sort of terms related to that. But he did that really well. So I went from housebound, like not being able to leave my house for about 9 months. There were a few things I could do. I could go to one store, but really limited, to schoolbound, like back to school, because of that intensive day treatment that didn't exist really. It didn't exist in the UK, might have done in the US. I don't think so, not specifically for anxiety.
Mhm.
And that stuck with me. I mean, that it more than stuck with me. It propelled and inspired my life, personal, professional mission. Schooling, bachelor's, master's, PhD in psychology, pre-doc, postdoc, founding the first residential program, non-hospital residential program in New Hampshire called Mountain Valley, opening up the Anxiety Institute in 2015, which is a day program.
Mhm.
And actually, the model of the day program is pretty close to what I went through in 1995 in London, except it's every day, 4 hours a day. but the same sort of model theoretical orientation and focus, so exposure therapy, focused treatment. So it's cliche. I'll summarize it. It's cliche, but inspired by my own personal experience, my own personal recovery, and continue to be inspired by the love of helping others.
Right. Wow. Well, that's, there's a lot in there, and I want to dive into some of that. But one of the things that you said there that really kind of caught my ears when you said sort of we're in the business of inducing anxiety. And I want to dive into that a little bit for the viewers, because you have a lot of therapists and or family members who are working with someone who has some sort of an anxiety disorder, whether it be generalized anxiety, whether it be a specific phobia, whatever it may be. And the thought of inducing anxiety just scares them, because it's like,
Mhm.
well, I'm supposed to be helping the person not be anxious, and you're telling me I have to make them more anxious? Isn't that hurting them? That's the phrase I hear all the time.
Cool.
Can you talk a little bit more about that?
Yeah, I certainly can, and I have experienced that as a patient or a client as well as a therapist. I think that there are therapists out there that have had training on anxiety and exposure therapy, but they are weary to provide it, and I understand why. I mean, the two main reasons is you don't want to lose your client, and the other is it's really hard, and it's related, but it's really hard to control the pace and the content, right? I mean, I'm going to give an example, a very sort of specific one, but arachnophobia, right? Fear of spiders. If every week we're exposing you to first maybe images of spiders and then imagining them, virtual reality exposure, yes, you think you'd see like a gradual reduction, and you certainly can. But what you can also see is, God, it felt like kind of traumatic each week. It's like, I use the example of public speaking. Why is that the most common fear in the world? Because no one does it frequently enough.
Mhm.
Like if I did every day, I'd be brilliant. I do it once a month and I still am terrified, you know?
Right.
So I think that that's a part of it, and then certainly many therapists haven't had the training. They may think, okay, it's intuitive that okay, we want to face fears, right, and decrease avoidance and get people feeling comfortable with symptoms, and then it addresses perfectionism, and so it makes sense, but it's really hard if you haven't had that practice doing that work, which I think in part makes a specialist, right? It's the number of hours and clients that you've done with it, used it with, that you feel comfortable in its delivery.
Hmm. Yeah. Well, so, when you talk about exposure therapy, that's a type of therapy that is used in several different areas, one of them being OCD, another being anxiety. So it's, something that's been researched and used for a long time. I do have a question for you. So if somebody has an anxiety disorder, something more specific, such as social anxiety, afraid to be at like cocktail parties, or if somebody has this fear of public speaking, or maybe arachnophobia. These are all kind of specific types of things that trigger their anxiety. But if you have someone who has sort of generalized anxiety, so they're just an anxious person about pretty much everything they see, do you find that exposure therapy is helpful for those patients, or is that a uh, different animal?
Sure. It's a great question. It's not a different animal at all. It's a tad bit more challenging, but only a tad. It still works really well because when you think about it, so we define the phobias, the type of anxiety you're referring to, initially as situational. You can kind of know the situations, the places, the times you're going to get that horrible, anxious, panicky feeling, right?
Mhm.
Generalized, the views are all over the place. They're pretty diffuse. But ultimately, what brings those two together, what connects generalized anxiety with specific phobias and social phobia, is a fear of getting anxious or a fear of dysregulation. It's challenges with uncertainty. It's discomfort and challenges with perceived or real threat. Uncertainty and threat are really what kind of drives anxiety. And so we can do exposures to uncertainty. to perceived threat, to what's unknown, to the control we want to have, we think we have, we believe we need to have. There's lots of ways to induce anxiety. So no, it absolutely works for generalized anxiety. I mean, there are a lot of anxieties about fear, or at the heart of anxiety is fueled by fear typically.
Mhm.
And whether that's a fear of spiders, planes, getting anxious, evaluation, judgment, rejection, abandonment, whatever the fear is, right? Contamination, it's all what links all those is threat, perceived threat, and uncertainty. And
Right.
so we can absolutely, use exposure therapy for all types of anxiety disorders.
Great, great. So the other piece that I wanted to follow up on was, you explained your own experience where you worked with a therapist, literally going around the city and getting all sorts of in vivo exposures to all sorts of things. And that's great if you can do it, but I know that based on therapist schedules and locations and things like that, sometimes they're not able to, they can either meet you in the office or they can meet you online, but to actually meet you out on a regular basis in public somewhere is not an easy thing to do. So with the Anxiety Institute where you're located now, how do you all handle that? How do you
Mhm.
get people the different exposures they need?
Yeah, no, I appreciate you asking that. Um, Yeah, I mean, I'll get, I'll say this. I know some wonderful anxiety clinicians. They've had amazing training, very credentialed, published folks, and they don't have the access to the client that we do. We're at an unfair advantage. We have a full immersion program that, we can work with a client with 4 hours a day, 5 days a week, where we can customize and tailor these exposures that are really linked to not only the fear that the client has, but what they're ready to handle.
Mhm.
Um, so our program, which is an intensive day, is a program that we've really put together a group of carefully selected clients that are really defined by kind of conditions they don't have, to be honest, but really they primarily have an anxiety disorder. They may have certainly some ADHD and depression, but what is dominating their life is this dictator of fear and symptoms that are consuming, hours of the day and huge amounts of energy. There's often some fear and resistance to treatment, which is a big mission of ours. We do not want anxiety, the condition itself, to stop someone getting treatment for the condition itself.
Mhm.
And we have a whole sort of process that I won't go into now, but of working through that fear and resistance to treatment. So we work, I guess one of the sort of secret sort of ingredients is pretty simple. We don't work with a lot of clients. So where a therapist might have a typical caseload of, let's say, 20 to 25, our clients have a caseload of 2 to 3.
Wow.
So right then, if you had a caseload of 2 to 3, yeah, you'd be able to say, let's spend 3 hours on Tuesday afternoon, facing those fears in real life. So
Mhm.
a lot of it is, yeah, just the resources that we have, the access to the student, and the model that serves both so well.
Right. Wow. So then in the right cases, your clinicians will actually literally go out into the community with the patient and expose them to whatever the issue may be.
Yeah, very much so. We call there's two sort of broad ways of looking at, and this is my interpretation. We all have our own language, in the clinical world. But the two sort of factors of doing exposure work is knowing the variables of influence, which are all the situations, the factors. Let's say it's performance anxiety or social phobia, and you're giving a presentation or a podcast. Those variables of influence might be: have I met you before? The lighting, the time of day, is it remote or in person? What's the topic? Are we talking about my own anxiety, or are we talking about today's politics? Um, I could think sleep last night. How did I sleep last night? And your body language. You have this very nice, warm, kind of non-threatening, by the way. So, but there's, what's amazing, and I've done a lot of research, and there's a lot of research out there. that individuals with an anxiety disorder are going to be obviously highly attuned to the verbal and nonverbal cues of others. Anxiety is a hypersensitivity and hypervigilance to external and internal stimuli, the way we feel and the perceptions of others. So all those are variables of influence, right? And what we need to do a really good exposure is to control those variables of influence to be able to induce a level of anxiety that's just right for you, just in that zone of what's tolerable.
Right.
If it's too much, it's like, Andrew, you're a good mate, but I'm sorry, you're gonna fire me, or you're not gonna come back next week, or make an excuse. So I've got to kind of really partner with you so that there's this trust. You feel like we're in this together, we're going into that dark cave together, and we're going to face the dragon together, but we're going to do it really slowly because you've got to feel in control, and I'm going to make you feel in control.
Right.
Anxiety needs that because we can only go at the pace that your anxiety will allow. This is not, and I'm using you, sorry to role play this out,
Oh, fine.
but it's, what sufferers feel like. It's like anxiety is somehow a choice. It's ingrained, this cultural stigma, but the reality is that it's a neurobehavioral condition that's separate. So we really make sure that we're referring to anxiety as a disorder. What the anxiety will allow you to tolerate, just like what my ruptured disc at L4, L5 will allow me to do on and off the tennis court.
Right. Right. But that's really interesting, and the reason I say it's really interesting is because it's extra interesting to me, and I'll tell you why. So, I work primarily or a lot with OCD, which exposure therapy is part of the treatment. And I'm always, explaining to my clients that in order for us to do this, we're going to intentionally engage your distress. We're going to try to get you into a position of distress so that we can do our work. But I also tell them that I promise you, we're never going to go to any level that you're not ready for. I will always tell you what we're going to do. We'll make sure you're ready for it, and we'll go there. But the thing that I've found after doing this for quite some time now is that the client will start off initially as a new client. They got to trust you and all this, and they will, oh, there's no way I could do that. No, that's just no way, no way.
Mhm.
And then you start working with them and you say, well, so here's what I think would be next, or here's where we should go. And again, we're not going to go anywhere you're not ready. And what I find is in many of the cases, they kind of want to be pushed to that level. So they'll say that they're not ready, but then they don't resist and they don't want to resist. They want to get themselves to do it. And then when they do it, they feel so accomplished that they were able to do this thing that they thought they couldn't do.
Yeah,
And
totally.
that it's just an interesting twist on it, because they're not so sure they want to say yes, but inside they really do want to get better.
Yeah, and I love that you're bringing this up, because it's almost like when they get a taste of what's on the other side of that fear. When you realize, yeah, okay, I'm going into this dark cave and I'm gonna freaking slay this dragon. It's sort of like starting to figure out there is no dragon. That feels really cool, right? And then there's times where, like, I don't think I can do it, but they need you, right? Just as you're trying, you got to kind of push them a little. So that's what I love about that kind of really collaborative work. It's hard to do this stuff on your own, really hard, especially in between sessions. But yeah, it's so cool to hear that you're doing that work too, man.
Yeah, yeah. So it's enjoyable because you can actually see the results when you get to the other side, and that's what I like most
Mhm.
about it. So,
Yes.
so for me, in my type of practice, it's excuse me, a 1 hour session. And so I don't have the ability to do anything intensive like you all do. So what I have not asked you yet is, who is your typical client? Age, gender? Tell me, what does a typical client look like for Anxiety Institute?
Yeah, sure. So we have quite a thorough screening process, because if we obviously are bringing in a client, and we call all our clients students, just so you know, so I'll use students,
Okay.
primarily. Um, if we bring in a student that has another problem, or a problem that sort of, is not understood by the other clients, or it's not a specialization of ours, it's going to, affect treatment in the milieu. So we're screening out certain things, so that diagnostically, I kind of mentioned that before, really primarily anxiety disorders. And when I say anxiety disorders, I am including OCD in that, from a DSM-4 kind of world. Age-wise, we're working with, in our intensive day program, 12 to 25-year-olds. We have a younger group. We kind of refer it to as a high school group because, typically it's 13 to 17. We'll occasionally take a 12-year-old on a case by case, but so a high school group and a college-aged group, and that's 18 to 25. Both all genders, so not gender specific in any way, gender affirming, and in all sense of that. There's 2 hours of individual work a day and 2 hours of group work, which is, I think, a pretty rare and unique thing to have an intensive outpatient program that you're getting 2 hours of individual by two different providers, both licensed credentialed therapists, experts. One is doing more of the, I'd say, sort of treatment planning, maybe some of the more tougher exposures, case management, family dynamics work, some cognitive processing. And then there's the second hour, which is more of the exposure focused work. And because you can't do exposure therapy for 2 hours, as you know, it's got to be done, over, brief period of time. And so those 2 hours are intensive, and they're working closely together. So that primary therapist and that exposure coach, as they're termed, are partnering. As a former tennis pro, I use this sort of as a poor analogy, but the first hour, if it's the tennis pro who is teaching you the mechanics of the game, so to speak, this, how to hold the racket, some strategy, court positioning. The second hour might be, and not to minimize their role, but let's hit 200 balls. Let's hit 200 forehands for the next hour, so it becomes muscle memory, because I don't want you to think about what do I have to do to hit a forehand. That's really one way to see the difference between those 2 hours. Also, that second hour of exposure behavioral coaching is going from learning to live with a condition to learning to live without it, right? So there's things related to independent living skills and planning return to school and taking a community college class, and many things to complement treatment. The third hour is a wellness hour. There's some options, but there's art therapy, music therapy, yoga, meditation, physical exercise, all about mind body, really mind body connection. I love it. I'm more of a sort of a all out behavioralist, but when I'm walking past the wellness room and I see, kids doing art and painting, and they're talking about life and their issues, it's somehow easier maybe when they're doing something else, and then, of course, often many are inactive and they're not working out or engaging in fitness, and now they are. And then the fourth hour is our group therapy hour, which is primarily CBT focused, with obviously space to process and support each other.
Great. So it certainly sounds intensive, but it also sounds very well balanced. But if I'm a parent, or maybe I'm an older student who's considering coming on my own, one of the questions that I have is, so how does this work in conjunction with school? Are they having to leave school to come into you, or do they do it after school? Tell us how that works.
Yeah, so it's a good question. So there's, the continuum of care that we refer to, on the one end, it's sort of hospitalization, and then on the other end, it might be local resources, a therapist. We are in this more intensive level of, or area of on the continuum, which is really defined by the intensity of the symptoms, the frequency of these symptoms, and the impact. And the impact for our kids is it's impacting school attendance. So if you look at our students, whether they're high school students or college students, at least I would say 50 to 70% of our clients are not attending school. they've taken a medical leave from college, they're refusing or avoiding school. The anxiety has impacted their freedom, their mobility. And that's really, why they need this intensive treatment. There are certainly some kids that, okay, they're able to get to school every day, but it's so physically exhausting. They can't focus very well. They're not doing their homework. More than several hours of the day is consumed by those, intrusive thoughts or whatever symptoms they have, that it makes sense that, okay, let's step away for, 2 months to do this treatment. We're going to partner with the school so we can try to do, sort of, we call it AI bound instruction instead of homebound. It's sort of, let's do instruction on site where possible. So, but usually they come to us because they sort of have to, you know. Over the summer, it can be because it's the clinical ideal, as I refer to it. It's sort of like, no, they don't necessarily need intensive day for 4 to 8 weeks, but it would be kind of the ideal, and we've got the time to do it.
Mhm. So in the cases, I guess this is sort of a two-part question. In the cases where someone is maybe transitioning back into school, if they've been out of school working with you all, um, and or in the cases where they have family members who are accommodating them and therefore inhibiting treatment, keeping it from being as good as it could be. How do you all work with that? Because I would assume a lot of teachers are not probably well versed on anxiety or how to work with a student, and a lot of parents need to learn about how to handle these things. So what do you all offer to deal with those things?
Yeah. Yeah, I'm pleased you mentioned that because, anxiety it feels very much like this individual experience, but it's a family system experience. But, a young child's living at home, it's going to impact the family. The family's going to fuel and feed it, often inadvertently. My mom didn't know 20 years ago that every time that she picked up the phone, that she was reassuring me. She just thought, hey, I love my son. I'm going to do what, I'm trying to make him feel better.
Mhm.
But of course, it was a vicious cycle, right? So, what I love about day treatment and what I don't miss really about residential, although I could have a whole podcast on what I love about residential too, but is we have access to that family system, right? They can come in. We have several hours a week, 2 to 3 hours a week of intensive family work, not just to support them, but they have a manual that they work through. There's co-parenting training. We use Ellie Leibowitz's space model, which I know you're familiar with, in addition to some other sort of evidence-based treatments, um, because we want to nurture, courageous parenting, interdependency. Anxiety is about a dependency, typically on escape, avoidance, and seeking rescue or refuge.
Mhm.
And we need to partner with parents to make that treatment successful. And it's wonderful to have access to them. So they're coming into the center. There are times where we'll go into the home. So it's a real benefit if they can live, locally within, 20, 30 miles.
Right, right. Yeah, it's that bit about, a parent is obviously interested in the well-being of their child. And so they are working as hard as they can to try to help their child with their anxiety. And what they don't know before they enter a treatment program is that maybe the things that they're doing are actually exacerbating the anxiety as opposed to helping it. And there is such a need for that educational component and bringing the parents and other family members into the fold. I agree with you. It's a family issue. It's not just an
Mm.
individual person issue.
I'm
And
curious about what's your experience like in working with a family in a sort of private practice model, especially when the client is over 18. What's that
Mhm.
like?
Well, so typically what I will do is if we're talking over 18, I will work with the patient first and we'll talk about their situation. Where are they living? Who are they living with? It could be they're living with family, could be they're living with a partner, could be they have roommates, whatever it may be. Or even if they're at work or at school. And we'll talk about, is there anybody that you're exposed to who is accommodating you? And again, because I do mostly OCD, are they accommodating your OCD? And we'll identify who those people might be if there are any. And if there are, then I'll talk with them about why this is not helpful for them and what, could be a logical, reasonable alternative, primarily having the conversation with the person, asking them not to accommodate them anymore, coming up with ways to change the typical accommodation behavior. I've even come up with a process of my own. I call it a comma don't. It's a four-step process they can use to work through coming up with a more effective way of dealing with things, that is it's non-judgmental, it's not attacking, it's not blaming, it's just dealing with the actual issue. And in almost all the cases, that is all they need. They're able to handle it themselves. Now, if it's a younger patient, or if it's someone who that's not working for, we may try and have a meeting where we bring in the family member or whoever it may be and just answer their questions, explain why this is important, explain why accommodation is not helpful. And typically, at the end of that conversation, it goes well. So I don't think I've ever had a case where someone has sort of rejected the concept and said, "No, I'm gonna keep accommodating." They
Mhm.
they do it because they feel that that's the best thing they can do for their child or their sibling without understanding the impact that it has.
Yeah. Yep. Yeah, and then just as somewhat new a parent myself, I've got a 3 and a 5-year-old. I see it all the time. I mean, any distress or something they're worried about, I immediately go to saying what will make them feel better. And
Mhm.
there's, obviously mostly there's normal times to do that, but it's really when it, obviously becomes a sort of a dependency, which I'm sure you see a lot with your clients, where it's the compulsion, almost it becomes a compulsion, I'm assuming.
Yeah, well, yeah, because they'll do the checking, and the parents will respond to the checking answers, or they will, seek reassurance, or they'll ask the parents to engage in the compulsion with them. Like every time you come in the house, you got to take off your shoes and immediately
Mhm.
take off your clothes and put them in the washing machine, and then you got to go change your clothes and take a shower. And okay, I don't want to make you upset, so we'll do it. But then I also get the ones where I've been contacted by either parents or spouses or other loved ones who are dealing with someone who is not being treated for OCD, but clearly has a very strong case of OCD, and the demands for the compulsions, the loved one can't, they just can't do it anymore. And so they contact me and they say, "What do I do? How do I deal with this?" And so we have to approach it from a totally different angle, because now you've got a person who is not receiving treatment, who really needs treatment, but they're not in a place where they're ready to accept that they need treatment. And so we have to kind of back end into it, and creating behavior change through changing your own behavior. And the biggest thing there that I typically get into is, if the person with the OCD is asking me to do a certain thing, then I typically do that. They're getting what they want, and that works well for them, but it's not really helping them with the OCD. But what I have to learn to do is I have to learn to not give them what they want and give them something different. And so if they're not getting what they want from me, they're either going to stop seeking it because now they're
Mhm.
not getting what they
Mhm.
want, which is me changing their behavior by changing my behavior. And that's, so you have to kind of back
You can
in.
slip into that cycle, right?
Yeah. So, but it can be really effective because the person who, you know, typically does a certain thing and gets a certain response from you, as soon as they stop getting that response from you, then whatever they were doing doesn't work anymore and they have to figure out something different.
Mhm.
So that's sort of the behind the scenes for me of
Yeah.
how I get behavior change in reverse.
Yeah. One thing I wanted to kind of mention, because I often talk about this topic with therapists in private practice. We deal with clients who really that resistance, and I'm not going to minimize it. It has interfered with access to treatment, where often they might need some short-term medication, just to get there, get to
Mhm.
us.
Mhm.
And often not medication, or it's just us developing a relationship before they even start. So we have a really cool admissions process where beyond sort of assessing a clinical fit, personality fit, level of care need, it's fostering a relationship where we can, the kind of like the gradual exposure starts at point of inquiry, really. It's like, I'm going to expose you to an idea of treatment and get you to a place of being able to make an informed decision based on what you know versus don't know, so they kind of feel in control, and then take one day at a time. The prospect of 2 months is, most people are going to be, no, no way, this is exposure. I'm not going to 2 months of exposure. That's crazy. Of course, it's not 2 months of exposure, um, but that has become almost like a part of the process before we've even started. And I didn't even know fully at the extent of that would be the case before opening the Anxiety Institute in 2017.
Mhm.
Um, and it makes sense. It's what took me a year before I was willing to do this work.
Yeah.
Um, and so yeah, take one day at a time and decide, all right, 1 week at a time. Am I going to decide to continue that second week? Make it based on your experience, what you know, like I said, based on reason and not fear is the goal.
Mhm. Well, and I can tell just from your answers that your approach in general with your students is one that is open and listening and accepting and kind of bringing them into the fold, because oftentimes I'm going to guess you probably experience this as well. You'll have some in my case I call them patients who come in and you know they talk about something, but then it becomes apparent that it seems like there's something else going on here, they don't
Mhm.
talk about. And in some of the cases, it's something that they're just embarrassed about. Like they don't want to talk about the fact that their OCD causes them to have certain types of sexual thoughts, maybe. So they got to get comfortable with you before they're going to be willing to open up about that. Or the other one where, you know, you're getting ready to start work with them. And, oftentimes in an initial interview, to me, it there's just something that says to me, there's something else here. And then you dig a little bit deeper and you find out that there's some other unresolved trauma, whether it be related or not. And so, and I know a lot of different therapists approach this differently. So, like I teach my clients, we don't talk about the right way, we talk about a right way, because there might be more than one right way. So a right way that I like to approach it is to address trauma or co-occurring disorders first if I can, because once I start getting into that exposure therapy and I know that we're going to be kind of taxing their distress levels, I want it to be as clean a plate as possible. And I found that to work really well, for me. Um, so you do have those cases where there's some kind of a block or something they haven't told
Yeah.
you or something going on, and you just have to give them the space to be able to open up and share that with you.
And I like to hear that. And I think we do a lot of that in our screening out process. I mean, certainly it's not that we don't work with trauma. There's certainly some mild complex trauma cases, but I do see PTSD and trauma as really quite a distinctive experience and its own specialization.
Mhm.
And we've got some staff that are experienced in that, but I would say we're more likely to refer PTSD client out to another expert. Um, I mean, it's still about fear, uncertainty, perceived threat, but I think some of the treatment modality has some similarities but differences. But I'm curious about what what your thoughts on that are.
Yeah, no, I agree with you. So you know, my particular practice, like I said, I focus heavily on OCD, but I also have a pretty decent focus on trauma. And I've been getting more into behavioral sleep medicine on top of that. These are
Mhm.
just that, and as well as Tourette disorder, tic syndrome. But there's
Oh,
a lot of similarities between some of these, but then you're right. When you talk about trauma or something, your treatment modalities are going to be very different than your exposure therapy that you're going to do for OCD. When you talk about, tic disorder, Tourette, that's closer to exposure therapy in a way. There's a lot of similarities, but there's differences. And then when you talk about sleep issues, now you're talking about a different type of CBT, but very prescriptive. But the point is that what I have found is those clients who clearly have trauma. Like I'll give you an example. So I had a client who had harm OCD, afraid that if a friend or family member comes over and they're in the kitchen, they may pick up a kitchen knife and stab them.
Sure.
Okay, pretty straightforward harm OCD case. But there was something else going on. And so as we dug into it, we found that this particular patient had a lot of deaths in the family or close people close to this patient. And they never had the opportunity to process that. And it really was an overriding factor in how they were able to function. And so we dealt with that trauma first, helped them to process through those things, to work through all of the trauma of all these deaths in their life. And then they were ready to deal with the OCD symptoms. And then we got into the harm OCD and the exposure therapy, all that. So that's an example.
Yeah, that makes a lot of sense. And I've just looked outside and there's a storm coming and you may hear thunder. So sorry about that. You asked, I think, earlier or in our conversation before we started about sort of some of the clients that we're seeing. And I'd love to just share like what I've I see these three kind of clusters. And lots of individual differences in between each cluster. But one cluster is the OCD spectrum. And since COVID, we've seen a huge spike in intrusive thought OCD, bad thought OCD, obsessive or intrusive dominant OCD, whatever you want to call it, right? Mental compulsions. I don't know why. Is it because first time in history? Probably not the first time, a perceived threat has become real, or every kid is no longer in school for a bit. I don't know. But I mean, 200%, 300% increase of, maybe a conversation for another time. But anyway, so this OCD spectrum group. Now, what makes this OCD at a level where they should consider us, in my opinion, is number of hours a day it's consuming, so frequency, intensity, and impact, and how small their worlds become. Is the radius of freedom decreased to a certain point around their house or their neighborhood or a few people? That's really definitely when they would come in. For us, it's not about complex comorbidity, really. It's just, acuity. Another cluster would be, and we do include picking, pulling, BFRB kind of conditions in with that. Another cluster is situational anxiety. So your social phobia, agoraphobia, panic disorder, specific phobias, that cluster. And then the third would be more of it's kind of linked to the first one, but it's kind of generalized generalized anxiety. But what we're seeing is sort of GAD perfectionism that can go all the way up to OCD perfectionism. Now, these aren't official DSM terms, but we're seeing a lot of like high functioning kids, right, who were doing really well in school and then set high expectations, self-critical when they don't meet them, to getting to a point of I can't write an essay or I can't even write a paragraph. I'm not checking my emails, chronic avoidance, and typically linked to a fear of failure and a fear of the future and not living up to their own expectations or the perceived expectations of others. But what happens with those kids? A lot of them untreated drop out of school, take a medical leave or burnout or so that's just I want to kind of make it clear as others going to see that is kind of about 30-40% of our clients right now have that kind of presentation where the fears are more generalized. It is linked to perfectionism in some way, and of course I'm a therapist, so I think all perfectionism is bad. There's no adaptive perfectionism. I don't know your philosophy, but those are sort of the three main clusters, and our model works kind of kind of well for all of them. Our treatment length, I should say, is around 2 months. It doesn't typically go beyond that. Minimum is 25 days. We feel we need 25 days, and it's a 20-day month because it's Monday through Friday,
Mhm.
to really instill enough of that progress, that desensitization, where, okay, we could step down to potentially 3 days a week or 3 hours a week. In some, we titrate the intensity of treatment based on what's needed, what's working. And that's great to have that sort of, flexibility.
Yeah. So I that leads into a question I was going to be asking you, which is this. Can you give sort of a generic example of what it might look like for someone to come to your program? What kind of state are they in? And then a month later, what do you typically see? I realize every patient is different, but
Mhm.
generically, what could someone expect to go from what to what by going through your program?
Yeah, sure. So I might have a slight proclivity towards going towards a panic, agoraphobia, social phobia case, because that's my subspecialty, and I wrote my dissertation, or my research has been on that. You're a full OCD expert, as other staff on my site are, but I will use a panic and agoraphobia client. But so we usually get the initial call from the parent. Sometimes it's the child or the young adult, but rarely. So 22-year-old, it might be the mom calling, and that's like our initial kind of pre-screen. We want to kind of understand what is going on with their child, or where they're at, or college, or they've dropped out yet, are they going to class? Get the basic information. Does it look like it's an anxiety, or is there something else? Ultimately, we're going to refer and get them the help they need. If it's not us, we're going to help either way.
Mhm.
After that, we get the data to see, okay, do we want to speak to the student? If they're away at college, which could be the case, we'll do a Zoom assessment with our clinical director at the site. We have 3 sites that they would go to, one of 3. Or if they're home, they would come in and have about a 60 to 90-minute in-person assessment. This assessment is no cost. It's good due diligence for us. It's due diligence for the parents. But we obviously want to make sure that we have a full understanding about their history. We're going to consult with the therapist, with their consent, obviously, the psychiatrist, because we're going to end up working as a team together. And then from there, we make the decision as a team, of accepting or not, or referring out. If we've gone to that step where they're coming in to visit, usually they're going to be admitted, but we're not afraid to say, hey, you know what? We think this other program is going to be a better choice, or we're going to go back to the referring therapist and say, this data that we collected, this will help inform your recommendation. And then from there, we typically start within the next few days. If anxiety, which it often does, might get in the way of getting to us for that first few day or the first few days, there's a lot of verbal, like remote coaching that we provide. We can come into the home to elicit that commitment. Near and dear to my heart is that part of it, because if someone didn't do that to me, I wouldn't be here today. Um, so there's some really great language that's linked to, like I said, motivational interviewing, emotion focused therapy, some, strategies that, I used to call kind of like, I don't know, hippie therapy, but it's about human connection, right? And authenticity. And when, you know what it is? It's like when I go into a home or I speak with a child that, yeah, they want help, but they have a fear of getting worse. They have a fear of getting better. Because hell, if I get better, I got to maintain it. And you'll know this more than anyone as an OCD specialist. If I get better, I lose the one thing that's keeping me safe.
Mhm.
Right? So you
Yeah.
got to work through that. And so when I go to the home or I'm talking to them on the phone, I'm really just trying to get them to think about the regret they might feel of not trying this, what their life might look like if they don't do this. um it's a cost benefit analysis, right? And there's really very little cost. I mean, you can try it out for a few days, and So anyway, that's often the support that the client and the parents can have, because the parents often need that. They're driving often the student in. And then from there, they're really coming in for their first, first day. We're not jumping into exposures. We're certainly doing a biopsychosocial assessment. It's a lot on relationship building, connecting them with the other students, because another unfair advantage that we have is this cohort of bright, sweet, like empathetic kids that are paralyzed and stuck by their anxiety, fear, and avoidance. But they're a part of this community that's this safe place where we can practice these skills and mess up and panic. It's unconditional, like positive regard and acceptance. It's that environment, which it's hard to do this work unless you really feel that it's a shared experience, right? It's that shared experience where I know what you're going through. I've been through it, so I know, and I'm going to be here for you, and we can get through this together. That's why we're so careful and in the selection process, and spend hours and hours and days working with a student for no cost, by the way. It's like, and I say that because I don't want families to not call because they think, well, I'm not sure if it's a right fit. And that's okay, that we're going to figure that out together, and it's okay if it's not. We have a really good, generous financial aid and scholarship process. We've had donations from alumni parents. We put aside money for scholarships as best we can. We don't want, there's two missions. I don't want money to get in the way of access to treatment as best as we can, and I definitely don't want fear to get in the way of access to treatment. Those both would break my heart.
Right.
So hope your listeners will just know that they can call for that free consult.
Well, that leads me to my next question related to that, which is, if somebody did want to get in touch with you to talk with you about their situation, what's your number? What's your website? How do they find you?
Yeah, sure. So we've got three sites, so and an admissions team, and there's four of us, and we work really closely together. And there are some cases where they'll say, "Hey, Dan, these parents might need your clinical expertise, or this child has quite a bit of fear and resistance. They might need your personal story just to even come to the table."
Mhm.
Our other staff on the admissions are very experienced at admissions. But anyway, we have a main admissions phone number, which is on the website. And this is not some office in Arizona or some call center. No, you're going to be reaching a human being. If not, there may be a message, but you're going to hear back really fast. Usually we pick up because there's four of us.
Right.
And that is that initial call. So I can give you my number. I don't know. Do you want me to share it right now in my email?
Well, why don't you give us the website so that
Yeah,
anyone watching the video can get to it and then look up whatever specific information they need.
that would be wonderful. Yeah, so it's anxietyinstitute.com. Um, and on there, right on the homepage, it'll say sort of need help or questions. There's the phone number there. Now that's the main number. And when you call that number, I think option one is if you're interested in learning more about the Anxiety Institute, you're going to go straight to our admissions team that will be waiting to take that call. There's also on that website a video of some sort of a montage of experiences of clients that have gone through the program,
Mhm.
and a wealth of actual resources. Let's say, you might not need intensive day treatment right now, but you want some resources, some skills. We've got a wealth of those resources.
Right.
Affirmation statements. We have our outcome data to show, how do we know what the Anxiety Institute is doing is working? One thing actually, Andrew, I forgot to mention earlier, is in our intensive day, it's the 20-hour week. We also provide a customized intensive, which is 10 hours a week. And maybe the most simplest way to look at it is we provide services from 2 hours a week to 20. So while the majority of our clients, yes, they're coming every day for 4 hours, there are times where a student is attending school, but their anxiety isn't impacting it at a level where they need to be removed from it. But boy, could they use, 2 hours a day after school or an hour a day after school. We can still provide that customized intensive program if that's needed.
Wonderful. Wow. So this is all great information, and it's nice to know that you're out there, because there are a number of people who need that higher level of care, and they're not going to be able to do what they need just with a outpatient, you know, clinician once a week or something. And it's great that you have the resources that you have, and the approach that you take sounds very welcoming and caring and open to the type of people who really need that type of understanding to feel comfortable enough to get the treatment in the first place. So,
No, thank you, Andrew. That means a lot. Yeah, that's really absolutely what we try to do. And we stay true to the evidence-based model, as I know you do. We want the same outcomes, as we say to our clients. We're both investing in outcomes, and we're going to make a data-informed decision about, hey, shall we work together? Shall we continue this treatment? As you mentioned, it's kind of cool with what we do because we're treating something that's treatable, and that progress is something you can track.
yeah.
Yeah.
Yeah, that's that's my favorite part about some of these things, is to watch someone go from a place that they just don't want to be in, and then not too much longer, and it doesn't take a whole lot of time, and they get to where they want to be, and to see the relief and the weight off their shoulders, and the fact that they can now do the things that they could not do a month ago or 2 months ago, whatever it may be, is it's worthwhile to me, because it lets me see that the work that I'm doing with them pays off. I
Mhm.
can see the results, and that's what I like. So,
Oh, yeah, there's nothing better than that. Definitely.
yeah. So, all right. Well, Dr. Dan, thank you so much for taking the time out of your day to join us and share with the audience all about anxiety and how you treat it and what you do. Again, it's anxietyinstitute.com. You'll be able to find all the resources you need, and free call, free consultation, basically, it sounds like. So I encourage you
Absolutely.
to take advantage of it.
Thank
So
you so much, Andrew, for this time. I really enjoyed it.
great. Nice to have you here.
Thanks.